hear that. But the next scenario is Guardians of the Galaxy. We've got Johnny, who's the ED consultant, Seraj Haq, who's the SPR on call for TNO, and Ahmed Mustafa, who's the SHO on call with him, and who'll help him out if he's struggling. So the scenarios as follows. So Seraj, you're the SPR on call during wave 3 of the pandemic. ED referred 2 pediatric both bone forearm fractures for manipulation, but then won't provide sedation despite there being a clearly described pathway. The hospital is full and the children could avoid admission. The parents are anxious. How do you approach this scenario with Johnny, who's the ED consultant? Again, you'll have 10 minutes to resolve the scenario together. Then there'll be 5-minute summary and questions from the main panel.
Hi, yeah, my name is Siraj. I'm the ortho-reg on call.
You've come to admit these kids, have you?
Yeah, I've come to see the 2 patients that have been referred. Both a couple of young kids with forearm fractures. Is that right?
Yeah, they're pretty off-ended. They're like 60 degrees angulated.
Okay. Can you tell me a little bit more about the patients? What information you have for me?
So there's a 6-year-old kid and a 9-year-old kid. Both parents are with them. Both parents are crying. Both kids are crying. We haven't got their COVID status back on them yet. They're neurovascularly intact, and they need it manipulating in theatre.
Okay. Well, thank you for seeing the patients and thank you for the referral. From what information that I've got so far, either from the x-rays or seeing the patients, I think we could probably manipulate them under anaesthetic in the A&E today and hopefully get them home in a cast after that. Would you be able to help me in kind of facilitating that today?
So as you know, we're in COVID 3, so these would potentially be aerosol generating procedures. I've got a full resus, full peds, the hospital is full. So in short, I've got no one who can do the anaesthetic for you and no one who can monitor or manage an airway if all things go tits up.
Okay. Just as you're saying, the hospital is full right now, and if possible, it would be good if we can work together to try and avoid admitting these children. When I think there's a good possibility that we could get them away home if we can do the manipulation within A&E. You're saying there's nobody free at all that would be able to assist?
The hospital's completely full. What with COVID, we've got extra precautions going on, PP and all that stuff. We've got patients backing up into the ambulance bay. I've literally got no one. If there were there was any neurovascular compromise, I could push people around potentially for at least one of the kids, but I've got 2 kids here now, and they're not neurovascularly compromised, and they're all crying.
Mm-hmm. Yeah, no, I understand that they're crying and they're upset, and it sounds like the parents are quite anxious as well. I think just overall from the situation, I think I understand that there's a kind of well-defined protocol for getting the anaesthetic done within the A&E. Is there any kind of other reason that that protocol couldn't go ahead?
As I said, we've got a complete lack of space, complete lack of staff, and we just can't facilitate that. I mean, I helped write the protocol, so I know exactly what it's about.
Mm-hmm. Okay. Apart from admitting the patient, do you see there's any other way that we could kind of work together to try and sort this out here and hopefully kind of avoid an unnecessary admission for these children? No. Okay. Well, it would be good if we could, have a chat and have a think of what we could do. I could certainly see if there was any of my anaesthetic colleagues available, give them a ring, see if they would be free to come down and get this done here. That way we can get the anaesthetics done. I'd be happy to give the arms a bit of a push to get them in line.
That takes care of one problem, but the other part of the problem, as I said, is space. We have no space. So where would you plan on doing this?
Okay. Is there not any room within the A&E where this could be done at all?
As I said, unless we end up putting patients within social distance of each other, then not really. Unless we put people back out into the car park and that. I mean, we get you guys down here every week saying, don't worry, I'll push it back, I'll get it right. And you always put it up, and it always goes to theatre.
Okay. I'm sorry to hear that you've had that kind of poor experience with our team and our colleagues in the past. Certainly we want to avoid situations like that as best as we can. certainly, at least, if we could get one of the children done, I think that would be a good start. Better to at least avoid one unnecessary admission than both of them.
I mean, going back to my previous point, how many of these are you, and can you guarantee me that you'll get it right?
So, I can't guarantee that. That would be dishonest of me to give you that kind of guarantee in this situation. All I can say is I would certainly do my best. We'd work together as a team to try and get the best outcome for the patient. As you're saying, things can go wrong, and I can't guarantee that'll be the case, but we will do our best.
Can't you take these kids around to the fracture clinic and just do it there? You got the plaster and everything. Just take it off our hands.
I'm not sure if that would be the safest place for us to do something like this, and the safety of these children is my kind of utmost priority, and you would agree it would be the same priority for you as well. So I don't think the fracture clinic would be the most appropriate place to do that.
What about if we move some of the minus patients around to fracture clinic, and those that don't need airway protection, free up some space and then do it in one of those bays, if you can guarantee you'll get it right?
Again, like I said, I can't guarantee it, but I think that sounds like a reasonable compromise that we could come to in terms of freeing up space. You've said that you're very busy right now, and fracture clinic's just around the corner. That's potentially something that we could do to try and work this out.
Have you got a consultant on call who could authorize that to make it happen, or a trauma nurse?
I can certainly make a phone call to my consultant on call. It would be good to get their approval before I went ahead and did something like this off my own back.
I think before that, probably it's best you come and see them and have a chat to the family, because as I said, the parents are pretty hysterical, as is the children, or as are the children, and then take things from there.
Yeah, definitely, I agree. It would be really useful for me to see the patients, see if I can alleviate some of the anxieties of the parents as well, and then hopefully we can all come together to make a plan of how we can approach the situation.
Right. Nice. All right. So, Ahmed, how did you interpret that whole scenario? Thank you, Johnny and Siraj, for acting so well. And Sunny, why don't you put the poll up again whilst Ahmed, do you want to give us some feedback?
Yes. So, I see that Siraj has been very patient. He was very informative, and he tried to push very hard to do the child safely in ED and to save the patient going to theaters. Although there was as normal some resistance, it's not personal, but it is because of the resources and the current situation. But I see that Siraj was very kind, very passionate, and he was very patient. On the other hand, he didn't have much to do. So this situation actually happens to me personally on the day, on most of my on-calls when I'm on-call registrar, with always arguing with the ED consultant to do sedation ED, speak to the anesthetic registrar to come and do sedation if they can't do that, and this really difficult situation to handle. Even if we speak to my consultant, what will he or she do? They can't approve that to be done in the fracture clinic. All they can do is just say, yeah, admit the patient, and then to be done on the next list if the patient's neovascular entitlement is closed.
Thanks for that insight, Ahmed. This happens on a daily basis for you, and yet there's still no resolution for it. Johnny, I thought, was actually probably the most cooperative ED consultant there. He actually gave Siraj quite a leg up there with the options of moving things around, and that was perhaps a bit more charitable than the other consultants that I've experienced this from. And I'm sure we'll soon find from the results of the poll that most of us have been in the same situation. So, Ahmed, can I ask, in the situations where the hospitals that you've been, has there been any kind of protocol for managing both bone forearm fractures or pediatric sedation fractures, sedation for fractures, manipulation?
To be honest with you, there is no like an agreed protocol, so that's why it's quite difficult. And mostly the protocol is to take patients to theaters. All right. But if the patients are like quite older children and neovascular intact and severely displaced, then yes, sometimes we tend to speak to the ED consultant to try to do it in ED. However, if it gets escalated to my consultant and to higher level, then the decision will be admit the patient and take to the next list.
Okay. So, Johnny, how did you feel Siraj handled that? Because you've obviously, so just to say that the results of the poll indicated that we are not alone. 90% of us have experienced this. And so this is a frequent scenario, something that we perhaps need to have, how can we deal with this in a better way across the nation? And if we go back to last week, we had a quality improvement project. Maybe this could be a national quality improvement project. Johnny?
I think you did well. I think there is no answer to this when you're left with, we have no resources, no space, and no way. It's not I don't think there is an obvious orthopedic solution to that other than his suggestion, which I thought was very good, of trying to get the anaesthetist down. But an appreciation probably that in COVID wave 3 or 4, whatever it's going to be, that realistically that's probably not going to be an option. Because everyone's going to be tied up on ITUs and in theatres with ventilators or whatever. I don't see a practical solution to these things other than potentially saying nasal fentanyl and just discussion with the family more so than A&E to get the family on board. And I think if you get the family on board, it's a lot easier then to have their support in trying to appease the A&E consultants. When I was having a chat to Richard Kendall yesterday, and he was surprised that there isn't a regional policy in place for this yet, and our experience continues to be a struggle. And I think they're trying to look at that to see how that could be managed better. But I think if you get across to one consultant in the department, particularly in the places that we work in, I think there are 20-something A&E consultants, and so you have to get the majority of them on board to effect change across the department.
So just for the uninitiated, Richard Kendall is one of our ED consultants. That's who Johnny was referring to. So an ED consultant who helped write up the pathway for pediatric sedation. And as highlighted, this is a national problem. It's not isolated to yourselves. But Siraj, you handled it very well. How did you feel? Did you feel like you were progressing?
Yeah, I think it went okay. I think the conversation went in the kind of right direction overall. It's difficult. It's difficult knowing what to say when he's saying, we have nothing. There's nobody, no place. We have no resources left. It's hard to have a counter argument to that kind of chat. So, but yeah, I think
you did come up with some suggestions, and as Johnny's highlighted, you came up with the suggestion of what about if we get an anaesthetist? I know that wasn't didn't answer the space thing, but because you came up with a solution for the anesthesia aspect and the staffing aspect, he then felt like he could offer something from a different resource aspect. And I don't know, maybe it was a kind of like, if you can, share something with the the person on the other side that you can then receive something on in return. So it was good that you were trying to think of solutions, and it's important to continue doing that and never give up. But the other thing is what we talked about, understanding people's the other person's anxieties. So what we assume is that all the ED consultants will be able to provide pediatric sedation. That's not true. It's like us being asked to do spinal surgery or pelvic and acetabular fractures. We are not all we don't all have the skill set. So don't assume that the people that you're talking to necessarily have the skill set, and that may be a reason why they're blocking something as well, is because they don't have that. But by providing a alternative solution like you did with the anaesthetist, they became more forthcoming, and it may have been that's what was the main block to it. I'm really keen to hear the results of the CRAFT trial, because that may help with all these manipulate. Are you all aware? So hopefully everyone on the webinar is aware of the CRAFT trial. Pranay, do you want to? I can see your ears are pricked up.
So I'm actually the trainee PI for the CRAFT trial, in Birmingham Children's Hospital. And it's actually a very good study. So if anyone is interested, they can join the WhatsApp group created by Prof. Perry, which I can put the link here, so anyone can just
please do.
Link, and go there. So it's quite a nice one. You'll find lots of resources and lots of comments from Prof. Perry personally. He's the chief investigator for this study.
So the CRAFT trial is for just for the uninitiated, children's radius fracture trial. And it's basically whether you should manipulate or not, and so that it will help answer. So if you get your hospitals engaged in that trial, then suddenly the ED department will have to provide the resources and will be more compliant with you. So that may be something. And then Siraj, in terms of your answer to, I can't guarantee it, that they won't go to theatre. So Johnny was alluding to the fact that there is this misperception that all fractures that we manipulate will go to theatre at a later date. ED kind of think that we're just kind of temporizing them, but actually it's once again answering that or helping them to understand that if you do this now, you may save the patient not just admission, it may save them an operation, full stop, and then their whole experience and that experience of the parents as well will be enhanced. So, Pranay, did you have any?
I was just going to say, we know that, this sort of management really takes great leadership to start off in the first place. I mean, the CRAFT trial, obviously by Dan Perry, who's sort of doing lots of different trials with PEDS, but also James Hunter, who's leading the PEDS GIRFT. It's off that work from GIRFT that has now, they've reviewed the practice of sort of pediatric manipulations in ED, and that has led to the development of the BOSE guidelines. So just showing that even a small idea, because he's been practicing this in Nottingham for over 20 years, has basically now led to it potentially becoming a nationalized thing where we can avoid needing to do this sort of stuff. But the most successful units in recruiting to CRAFT and also in managing patients with forearm injuries is where there is a good relationship between ED and orthopedics. And again, that's something that takes a lot of time and engagement from both sides. And actually, COVID has probably helped us accelerate that a lot, because, we were managing stuff over COVID where we weren't seeing people as much face to face. And I think we should utilize this time post COVID in the first year to really try and develop that relationship and build those care pathways in hospitals.
Great. Thank you very much.